Scapular dyskinesis by Carly Schlensker. Scapular dyskinesis pathology. Scapular dyskinesis occurs when the scapula does not move correctly during certain arm movements. It is also known as sick scapula. SICK stands for scapular malposition, inferior vertebral scapular winging, coracoid tenderness, and kinesis abnormalities of the scapula. Scapular dyskinesis is impairment of optimal shoulder function. Correct scapular function is especially important for overhead athletes. Scapular dyskinesis presents itself clinically as asymmetry in scapular motion compared to the contralateral side, either an elevation or descent, which leads to disrupted motion. Ways to prevent scapular dyskinesis from occurring are proper warm-up and/or stretching prior to throwing or overhead activities, obeying proper age and league pitch counts and guidelines for baseball or other applicable sports. Begin teaching and practicing proper throwing and hitting mechanics at a young age. Signs and symptoms. Pain and/or tenderness around the scapula when using the arm overhead or carrying heavy objects with the arm at that side. Snapping or popping sensation around the scapula with shoulder movement. Be sure to look for asymmetrical posture. The affected side will usually sit lower and it will look rolled forward. Another thing to look for is winging of the scapula. It's instability of the shoulder and it will feel like the scapula moves out of place. Loss of strength with shoulder and arm use is another sign. Mechanisms of injury. Muscle weakness or imbalance, poor overhead mechanics, overuse or repetitive motions such as throwing or serving, altered muscle activation patterns, nerve or muscle injury, osteoligamentous injury, or proprioceptive dysfunction. Other common causes are attributed to soft tissue, for example, intrinsic muscle abnormalities, inflexibility, or abnormal muscle activation. There are 3 types of scapular dyskinesis. The first type is inferior angle prominence. At rest, the inferior vertebral scapular border may be prominent dorsally. During abnormal motion, the horizontal plane movement in the inferior angle tilts dorsally and the acromion tilts ventrally over the top of the thorax. Common associated findings with type 1 scapular dyskinesis are tightness and shortening of the pectoralis minor. Type 2 is characterized by vertebral border prominence. At rest, the vertebral border is prominent dorsally. During abnormal motion, the movements in the frontal plane are characterized by the vertebral border of the scapula tilting dorsally towards the thorax. Common associated findings with type 2 are weakness or reduced activation of the serratus anterior and lower trapezius. Scapular dyskinesis type 3 is superior border prominence. At rest, the superior border is generally elevated and the scapula is often anteriorly displaced. Abnormal motion for type 3 occurs in motions of the sagittal plane. During these motions, the shoulder shrug motion is very evident. With type 3, common associated findings are tightness or overactive upper trapezius or weakness and reduced activation of the lower trapezius. There are no official special tests for scapular dyskinesis, but the best way to diagnose it is through visual observation. It's easier to recognize irregular scapular motion by having the patient perform active resistive motion. Have the patient perform 5 repetitions each of shoulder abduction and shoulder flexion. Make sure to have the patients keep their thumbs facing up and their elbows straight to keep their motion in the frontal plane. While they perform these movements, you will be rating each one based on how abnormal the scapula is moving. As you are observing the active motion that they are going through, you are looking for 2 things: scapular winging and scapular dysrhythmia. To look for scapular winging, watch the posterior vertebral border of the scapula being displaced. Another thing to watch for is the inferior angle of the scapula movement away from the thorax. To notice scapular dysrhythmia, you want to watch for an excessive amount of elevation or protraction of the scapula before 60 degrees of humeral elevation during flexion or abduction. Dysrhythmia is also characterized by a stuttering motion during humeral elevation or lowering. Another thing is rapid downward rotation during humeral lowering. First, you will rate the left and right scapulae independently for both flexion and abduction as either normal, subtle, or obvious abnormality. Subtle scapular winging abnormality is characterized by mild or questionable evidence of abnormality, but it is not consistently present. For obvious evidence of scapular winging, there's 1 centimeter or greater of scapular displacement away from the thorax. Rating the amount of dysrhythmia abnormality in the scapula is quite similar to scapular winging. Subtle is mild or questionable evidence of abnormality and it's not consistently present, while obvious is strikingly clear, apparent abnormality evident on at least 3 out of 5 of the repetitions in either abduction or flexion. After you've rated each scapula individually on each motion, you're going to rate the motions of flexion and abduction together as either normal, subtle, or obvious. Normal, both flexion and abduction were rated as normal, or 1 motion was rated as normal and 1 as subtle. For subtle abnormality, both flexion and abduction were rated as subtle. And for obvious abnormality, either flexion, abduction, or both motions were rated as obvious. What factors can predispose you for scapular dyskinesis? Sports involving repetitive overhead activity, increase in throwing velocity, loose joint capsules, history of or repeated shoulder injuries, poor physical conditioning, meaning strength and flexibility, or kyphosis, which is an excessive posterior curvature in the thoracic spine. Management and treatment. For scapular dyskinesis, the most important thing is strengthening the muscles that stabilize the scapula. Stretching is also important. Since people with scapular dyskinesis are so predisposed to other shoulder pathologies, they should avoid throwing or repetitive overhead motions until their scapular positioning improves. Kinesiotaping is also a good technique to help assist in correct scapular position and posture. If your athlete isn't able to manage their scapular dyskinesis and are not showing any signs of improvement, they can always be referred to an orthopedic physician. Most likely, the physician will refer them to a physical therapist that can help them through rehabilitation techniques to strengthen the stabilizing scapular muscle. For my PICOT analysis, my population consisted of 72 elite asymptomatic overhead athletes. The athletes are around 17 years of age, around 5'9", and around 150 pounds. Their body mass index was 21.8 with a standard deviation of plus or minus 3. The intervention they used was splitting the participants into 4 random groups. They used rigid taping, kinesiotape, a placebo tape, and a control group with no tape. The participants were taped according to the group they were assigned, and the control group was not taped at all. The comparison was the 4 groups were evaluated for observable scapular dyskinesis immediately after their taping type and 60 to 72 hours after they were taped. The groups receiving tape were compared to the control group. The outcome of the study was to determine and compare the short-term effects in asymptomatic overhead athletes of rigid and kinesiotaping for scapular dyskinesis, scapular upward rotation, and shortening of the pectoralis minor. The time frame for the study was 60 to 70 hours after the participants were taped. Thanks for watching!